Good evening, ladies and gentlemen. Welcome to Day 2 of the First Asian Oncology Society Conference. We will start this evening's session by meeting the experts on breast cancer. The chairperson of the first lecture is Dr. Jorge Ignacio. He is the past president of the Philippine Society of Oncologists and currently the section head of medical oncology at the University of the Philippines Philippine General Hospital, where he is also the chairman of the Cancer Institute. He holds an academic position as a clinical associate professor at the University of the Philippines College of Medicine. May we call on Dr. Jorge Ignacio to introduce our first lecturer.
Good evening, ladies and gentlemen, and welcome to our Meet the Expert Session 1 on breast cancer. Our first speaker is Dr. Paul Carnes, BM, BCH, MA, MRCP, FRCR, and all those suffixes you can think about, who will give a talk entitled From Evidence-Based Medicine to Value-Based Care Medicine, addressing access to treatment in the genomic era. Dr. Carnes is part of the steering group for the European School of Oncology Working Party on the access to innovation in cancer treatment. He trained in medicine at Oxford University and in oncology at the Royal Marsden Hospital, London, UK, before becoming a consultant oncologist in Bristol, UK. He is a visiting fellow at the Malaysian National Cancer Center, where he co-directs the program on value-based care medicine, as well as being a life member of the Malaysian Oncology Society. He is part of the faculty for the annual ECCO European Cancer Organization meeting and the ESMO Barcelona, and speaks on innovation and value-based medicine. He is part of the team that developed and presented evidence to the Oncology Advisory Drugs Committee of the FDA for the first successfully approved US biosimilar, and is a faculty for the continuing medical education program of the European Association of Hospital Pharmacists in 2016, 2017, and 2018, and a core lecturer of the European School of Oncology. He is also a part of the British Medical Journal Roundtable Group on Biosimilars, a faculty member of the DIA Regulators Meeting on Biosimilar, and an advisor on medicine and biosimilar policy on several national health systems, both in the EU and beyond. Ladies and gentlemen, with great honor, Dr. Paul Cornes.
Good day, I'm Paul Cornes from England and the European School of Oncology's Task Force on Access to Innovation in Cancer Treatment. Several times a year I switch my base to the Malaysian National Cancer Institute and our program in value-based cancer medicine. Here are my disclosures, and a thank you to Viatris, our sponsors for this session of the AOS meeting today. We're here because the world of medicine is changing. Our world is dominated by non-communicable diseases, including heart disease, stroke and cancer. And it's a worldwide problem, such that the world's most important serious illness today is cancer. It's the leading cause of death. It'll affect 1 in 4 Malaysians, and that risk is doubling every 20 years. And it's true, even in the year of pandemic COVID-19. There's good news for cancer treatment. Worldwide we're succeeding. Pretty much every health system is improving outcomes. Here's the score for mine. We're improving at 1% a year and have done for 20 years. If we continue that way, cancer will be eliminated as a major cause of death in our under 80-year population by 2050. We know how to improve outcomes: prevention, early diagnosis, and better treatment. and better treatment matters. We estimate that more than half the life years saved in the last 50 years in cancer have come from better treatment. So how will we make cancer a thing of the past? The map of the way forward is here in the Hallmarks of Cancer paper by Hahnemann and Weinberg. They say that cancer is complex, more than 200 different diseases. But every cancer is explained by the dysregulation of just a few unregulated cell control pathways, and therefore all that diversity of cancer could be controlled by a limited panel of concurrent targeted precision therapies. And already that's changing how we do medicine. When oncology started, it was anatomic. You had breast cancer because it began in the breast. Now our view is changing. Breast cancer, we know from biomarkers, is about 8 different diseases, and there are 8 different best ways of treating it. Where are we heading? Well, it's genomic therapy. Here's the Cancer Genome Atlas. It's the first generation map. If you find the pathway that's dysregulated, you can pick the optimal drug treatment. We don't have a best drug for every pathway yet, but look at the speed of innovation. It won't take long. When we get it right, remarkable things happen. Tumours disappear in 11 days. Already with gene-directed precision therapy, the current drugs we have work 6 times better. Where we're heading is straightforward. The anatomic diagnosis will go, and instead it will be a genomic diagnosis. The pink ribbon of breast cancer will be a thing of the past. Where we're heading is clear, and a patient's going to ask us, how are you going to treat my cancer? And we're going to say, well, at any one time a typical tumour is suffering from 3 dysregulated pathways, and therefore we'll need 3 concurrent precision targeted cancer therapies to transform it. The latest control of pathways comes through understanding the immune checkpoint pathway. But it's one of many, and the principle is clear. By combining non-overlapping toxicity therapies, we improve the overall outcome. That would look the same, for example, in the way that we treat tuberculosis today. Where are we heading now? It's already here. Multiple concurrent targeted therapies. That's double therapy. And already the first trials of triple therapy, because it's logical. A patient's going to ask, well, doctor, will my health insurance cover that? And I'll tell them, well, here's a problem. The average cost per month of a novel innovative cancer drug is about $10,000 US. So if I need 3 drugs concurrently, it's going to cost more than $250,000 per year to treat the world's commonest serious illness, cancer. We're going to struggle to afford that. It's 8 years' earnings for the average Briton, 6 for an American, 13 times for a Malaysian, 60 times for someone in Vietnam. At a time when most healthcare systems struggle to afford 1 targeted precision therapy, I'm telling you we're going to need perhaps 3. So we have a problem. Just when we can understand how we could control cancer and make it a thing of the past, we could fail not because we don't understand the science, but because we can't make the economics work for us. Already, access to innovative medicine is a problem. Of the world's 200 nations, only 3 access at least 75% of those drugs. Only 9 access more than half, and that leaves 190 nations or so struggling behind. But if health is a human right, then access to the medicines that deliver health must also be a human right. But here's the reality: the only treatment that works is one that we can afford to give, and on our current spending patterns, much of healthcare is unsustainable, particularly in cancer. It hits the pockets of our patients. The Action study, looking across many Asian nations, showed that a year after diagnosis, only a quarter of patients were alive and financially stable. The reality of cancer care now is stark. It's not affordable for most patients, many payers, and nearly all governments. So when you see headlines, bad headlines about cancer, you know it's real. But it's not the only bad headlines. The lifetime cost of managing diabetes or rheumatoid arthritis or Crohn's disease, or putting a patient on hemodialysis is equally expensive. Policymakers grapple with this. They want to improve the health of the population. They want to assure access to medical care. And to do that, they have to have efficient use of the resources. And they know something important. Money doesn't buy life. To make a health system that will guarantee an average life expectancy of more than 78 years can vary threefold in costs between different health systems. And it's not just life. What about quality of life? To build a health system where 80% of your life is lived free of disability, the spend between different health systems varies more than tenfold. The first economic lesson is clear. It's not just simply spending more. The association between healthcare quality and cost is very, very weak. There's the paper to look at. But equally, I'm not advocating for cuts. Suppose I offer to sell you a car at half price. It sounds a good idea until you understand the details. Next generation doctors need to learn economics, so let me teach it to you. It's not difficult, because economics is not primarily about saving money, it's about using scarce resources as efficiently as we can do it. Economists never say a treatment is cheap or expensive, they say it's cost-effective or not cost-effective. And you all know more economics than you think. Economics is a problem because of the language, just like medicine. Economics is Greek. It's two Greek words, oikos and nomos, the household and wise rules. So economics is the wise rules for managing the household. And health economics is wise rules for managing healthcare, something that you and I will do every day that we go to work. There's a second key thing in economics. And this says, is what we're thinking about doing worth doing compared to the other things we could do with the same money? Let's put it simply. Each peso, dollar, Malaysian ringgit can only be spent once. Once money has been spent on one thing, it's a lost opportunity to spend it on something else. And economists call this the opportunity cost of spending. We want to make sure every time we spend resources in our health systems, we spend that money well. Economics is at the heart of the WHO's value-based medicine program called More Health for the Money. They tell us that all countries can do something, and many of them a great deal, to improve the efficiency of our health system, to release resources that could be used to cover more people, more services, and more of the costs. They tell us that of all the 10 leading causes of inefficiency to address, the number one is spending on medicines. They tell us to buy the most valuable medicines in the most cost-effective way. What do we mean by value? So in choosing the most valuable treatment, we have to just put economics into play. Remember, price is what you pay and value is what you get. So the price of a diamond is around $7,500 per carat, and it doesn't make you live longer. That's the cost and that's the effect. Contrast that with, say, water. 52 cents a cubic metre and you're dead within 72 hours without it. Now you know which is the most valuable between diamonds and water. Let's think about this in pharmacology. The two E's of pharmacology are efficacy and effectiveness. I want you to add a third E called efficiency or cost effectiveness. Remember, economics is a strange language. Make it simple. Is this worth doing compared to other things we could do with the same money? So faced with cost constraints, value-based medicine oncologists will look at the problem this way. They'll say we have to learn to give only the most clinically valuable treatments in the most cost-effective way. One good example is the Lancet Commission to deliver affordable cancer care. The Lancet Commission identifies 6 areas of practice where, if we were more cost-effective, we could save money to reinvest to more treatments for more patients for more indications in the future. The first 3 go together, and they say, don't give a treatment of low or unproven clinical benefit. Now, you may ask, what's a low or unproven benefit? And I'll send you to the European and US cancer societies who are developing policies that address treatments with only minimum clinical impact, such as the ESMO Magnitude of Clinical Benefit Scale or the equivalent from ASCO. The next step is don't give treatments that patients don't want. Understand what patients want, listen to them when you're making a treatment plan. Then don't duplicate tests or services. Once is enough. Don't do an MRI scan if a CT scan is all you need. And lastly, particularly thinking about medicines, look for equally effective but cheaper treatments. For example, generic and biosimilar medicines. So when we need in cancer medicine to access innovation, we need a budget for that innovation. And all of that VBM teaching tells you where to get it. We need an innovation fund to tackle the rise in cancer. And from that, we need to take out savings from our current budget that don't compromise care and replace that every year with our innovation fund. We need to improve efficiency in cancer medicine by about 6% a year, and with that you can afford all the innovation that you need. So, think about our current problems. Can we replace with generic and biosimilar medicines to create an innovation? And that's the basis of the WHO rules of good prescribing. They say medicine use is rational, appropriate, proper and correct when the patient gets the right drug, in the right dose, at the right schedule, and at the lowest cost to both them and the community. Irrational, inappropriate, improper, incorrect use of medicines is when any one of those conditions are not met. Value-based health systems have recognised this. National Health Service England, you'll see, is now able to switch more than half its patients to a biosimilar within 6 months of the launch of those drugs. We regard these drugs as innovation and have a national policy driven by education to make them work, coupled with service impact studies. So, in practice, we can increase access, for example, to best practice in cancer chemotherapy, with more patients treated without changing our budget. We can save money with biosimilars of trastuzumab, which enables us to reimburse for pertuzumab, dual HER therapy. It works in Malaysia. By using biosimilar trastuzumab to cut costs, we're able to expand access to targeted therapy. None of this is new. Across Europe, the advent of biosimilars increases access to treatment. That's how brand competition works. But importantly, saving money means moving fast. Looking at the world's developed nations, you'll see the average rate of switching is around 33% at 3 years. And yet some nations manage much more rapid speeds. And that has a consequence, because this gap builds up, and that represents losses in finance to healthcare that can never be recovered, and that is money we could use to buy more treatments for more patients. Over the long-term view, the average developed world health system is going to take 9 years to reach its optimal uptake of biosimilars. Some will have reached that many years. And that means 9 years of an innovation fund with less money than you could have. So when the British Medical Journal said, how will we afford the biologic therapies that we need? The answer was here. We needed cheaper generic or more accurately biosimilar versions because they would cut costs and increase access. The potential fund is great. If we could buy the drugs losing patents over the next 5 years at a 25% discount, I would have $10 billion a year to reinvest into better cancer medicine. If we could halve the price, we would have $21 billion. $21 billion means 21 free blockbuster drugs for the world. So when you look at the nations with dramatically higher than average uptake of innovation, is it surprising to see that all those 3 nations, America, Germany, UK, have extremely high rates of generic dispensing, more than 80%. The UK and Germany now have biosimilar switch rates of more than 80% by the 2nd year from launch, and the USA, which has only had biosimilar since 2015, are already predicted to reach 60% by the end of the 2nd year on market. You'll want to know if that is safe. Are these savings that do not compromise outcomes? Well, I say there are three different ways to explain our confidence in Europe. You could understand the confidence from the medical and pharmacy societies. You could look at the big data and understand the performance of biosimilars since they were first introduced, or you could understand the science behind biosimilars. The societies that now endorse biosimilars include Europe's medical oncology societies, the hospital pharmacists, and of course our colleagues in the USA. The data is clear. We've had these drugs now for more than 10 years. More than 70 biosimilars have been approved and marketed. We have more than 2 billion patient days exposure with no evidence that these aren't clinical similars as well as biosimilars. The science is more complex, but essentially we have to match the structure and function of the original drug, its pharmacology, its clinical efficacy and safety, and deliver those drugs in the same presentation, ways of administration and strength. The regulatory comparison spreads over around 60 to 100 tests showing equivalence between the original drug and the new brand version. And that takes a lot of testing. A well-resourced medicines regulator, such as the European one or the American, takes around a year to assess a biosimilar, the same time it takes to assess a novel drugs. Their statements are important. They say, with over 10 years of clinical experience, biosimilars approved by the European regulator can be used as safely and effectively in all their approved indications as other biologic medicines. These drugs are extraordinarily similar. So the European Union has made access to biosimilars a central policy imperative for the financial sustainability of our healthcare systems. I'm grateful to represent many of our cancer societies at the European Commission, the European Government Committee Stakeholders event. And by 2018 we said there were no serious medical issues remaining over this class of medicines. They are as safe and effective as the reference drug. We can use them in extrapolated indications. A drug proven in one indication is the same drug to be used in another. We can switch brands partway through a treatment because they're so immunologically similar. And if you don't, there are now 178 clinical studies to confirm that science is correct. But generics and biosimilars are just one part of value-based medicine's approach to healthcare. This is the start of a journey that you'll want to follow up. It explains why we need a focus on value. Let's look at the European Union data. This is the cancer outcomes for European countries. The spend per patient varies 2 to 3-fold, and it can show no evidence of clinical benefit. Equally in Europe, for the same investment in cancer treatment, the outcome could vary by an absolute difference of 25%. And that explains a lot. So all this explains why medical decision-making is in transition. We are leaving the era of evidence-based medicine, which focuses purely on efficacy. Remember the question for EBM? You ask, does this intervention make you live significantly longer or live better? And now we move on to value-based medicine, which focuses on the effectiveness and value to the stakeholders. And we ask, is this worth doing compared with other things we could have done with the same resource? So my conclusions. There is little evidence that spending more will reliably improve outcomes. We have to learn to spend better. I need you to move from evidence-based medicine to value-based medicine to deliver the most clinically valuable treatments in the most cost-effective way. And this needs urgent leadership by physicians and pharmacists, especially in cancer medicine. The genomic targeted therapies we hear about at the AOS meeting this week really does have the capacity to transform cancer outcomes, but that innovation is already unaffordable for nearly every health system in the world. We need to remember the WHO program, More Health for the Money, and its rules for good prescribing. This is where value-based medicine began. It helps us to prioritize the most clinically valuable treatments and to deliver them in the most cost-effective way. Those rules work in practice. Generic and biosimilar medicines create an innovation fund to deliver the most valuable new treatments to our patients. The system that works so well in Europe and America works equally well in Asia. There's more to value-based medicine than just thinking about the drug budget, but it's the first of 10 steps advised by the WHO in its programme More Health for the Money. Value-based medicine offers many more opportunities to deliver better health to more patients in the future. And that's why it is an opportunity. The programme in value-based medicine from the Malaysian National Cancer Institute has saved the equivalent of a quarter of the national cancer drug budget. That's money that can be reinvested into future innovation for cancer patients. So successful has that been that value-based medicine has been adopted as the principal policy across all the divisions of the Malaysian National Institute of Health. It's seen as the way forward to deliver better care in the future. So when Jorge Ignacio asked, is this a policy that can be applied elsewhere? The answer is yes, yes, yes. But it starts with us here today, learning what value-based medicine means and how to apply it for our patients' benefit. Thank you so much.